Hi, Dr. Frederick. I hate to interrupt. You were on mute, so we can't hear what you're saying. You got to unmute yourself. But again, we're good to go. It's okay.
And I apologize for that. So let me just start back at the top. Welcome to another in our series of Making It Plain Town Halls, brought to you by the Black Coalition Against COVID's Health Professionals Coalition, the 4 African American medical schools, Howard University College of Medicine, Morehouse School of Medicine, Mehari Medical College, Charles Drew University of Medicine and Science, the National Medical Association, W. Montague Cobb Institute of the NMA, the National Black Nurses Association, and we are joined by our essential partners, the National Urban League and blackdoctor.org. I also want to welcome our other minority health professional partner colleagues from the Association of Black Cardiologists, the National Council of Asian Pacific Islander Physicians, National Hispanic Medical Association, and the Association of American Indian Physicians. I want to welcome all of the health professionals from the allied health, pharmacy, dentistry, and social work who have also taken the time to tune in tonight. And I especially want to thank our sponsor, Henry Schein, for their generous educational grant in support of this program, as well as the NIH, Anthem, CDC Foundation, and America's Health Insurance Plans. Tonight, we will hear from a stellar lineup of experts who will help us understand the latest information and strategies for disseminating COVID-19 vaccines and how minority health professionals can participate so as to maximize the opportunities for success. Participate in an effective and efficient manner, and advocate for equity and fairness as we support our patients and their communities. We won't be able to cover everything tonight, so be assured that this is just one in a series of those briefings that we will present to you. So stay tuned as soon as we come back from the holiday break for another one. We urge you to place your questions in the chat as the program unfolds, and we will answer them in the last half hour of our program after all our guests have had an opportunity to present. So with that, let me introduce Dr. Monsef Sloari. And Dr. Sloari has been the chief advisor to Operation Warpspeed. And I'd like to start off our conversation here. Thanks again for joining us.
Thank you for having me.
Now, the supply chain and logistical changes seem overwhelming at times. There seem to be a lot of moving pieces. So can you briefly explain the steps in that process?
Well, the supply chain, of course, started with setting up the manufacturing process, which was, in fact, the second step in what we've done in Warpspeed. The first step was actually to do the research and development of the vaccine, design them, test them in the clinic, etc. But in parallel, we set up the manufacturing. So the overall supply chain, from deciding to start manufacturing a batch of vaccine to releasing it from a quality control criterion, takes between 2.5 and 3.5 months. You have to use your fermentation, growing cells, for instance, etc., which produces the vaccine. And then you have to purify that vaccine, and you create what's called the drug substance, which you then have to run a lot of tests on that you have set up prior, of course. And the vaccine, the drug substance batch needs to pass all those quality tests. Then you have to take that drug substance and you formulate it. For instance, if I take the currently approved vaccine, messenger RNA vaccine, you have to embed the RNA, the messenger RNA, into a lipid particle. That work takes, again, a few days. And then you have to fill the vaccine that's now ready in sterile processes into the vials. And then again, you have to run quality control tests on that finished vial that usually take between 3 weeks and 4 weeks. And then you can release the vaccine. And then you can distribute it once it's approved and then immunize. So it's a long process, many, many steps, many tests. Sometimes a test can fail or can give an unclear result. You have to repeat it, which makes planning the supply chain for vaccines extremely difficult, particularly when you have no stock that can help you to smooth down the ebbs and the flows on your capacity to produce batches.
With that in mind, and given all those steps that you were able to bring together so successfully in such a short period of time, what's the current timetable for vaccine distribution and delivery to the states and localities?
Yes. So as you know, currently we have 6 vaccines in our portfolio of products. A first one was approved last week. A second one had a positive vote by the FDA Advisory Committee this afternoon, and most likely, we hope, will be approved tomorrow, and then, as probably Dr. Mezanier will explain, will be voted on by the CDC and ACIP on how to recommend its usage. The second vaccine should therefore also be usable as of Monday. And then there are 4 more that are going to come in February and in March and later. The 2 first vaccines allow us to distribute enough vaccines to immunize about 20 million individuals between now and the end of the month of December, and then another 25 to 30 million individuals during the month of January. And then by the middle of March, we would have completed 100 million people vaccinated. So we'd add another 50 million to the 20 and then 30 in December and then January. So quite a number of people. That represents probably the majority of the healthcare workers, the first line workers, the resident in long-term care facilities, and most people over the age of 65.
Okay. Well, why was the emergency use authorization chosen versus the regular FDA approval process? And what are the implications of such a decision?
Yes. So really the need for an emergency use authorization is the emergency word, which is the active pandemic that's ongoing. But it's very important to realize that the clinical development aspect, what defines the efficacy and the safety, critically, of the vaccine, has been run exactly according to the same criteria as when a normal licensure is produced, except for one thing. I'll come back to it in a minute. And the manufacturing aspects of the development have also been run exactly as they would be run for a normal licensure. The difference on the manufacturing side is that the documentation of the processes, the bureaucratic aspect that are important to document is more summarized. And just to give you an idea, the time that we project between having an emergency use authorization and then having the final licensure is 3 to 4 months. So there's not that many things that still need to happen. The one thing I wanted to go back on, which is very important, is that the follow-up of vaccinees in the clinical trial, which usually should be 6 months, has been decided, because it's an emergency, to be only 2 months in about 50% of the study population. That's a shorter follow-up, and that period of time has been defined on the basis that, looking back in the last 30 to 40 years of vaccine development, and many vaccines have been developed over that period of time, most safety events associated with vaccination and adverse events associated with vaccination take place, about 90% of them take place in the first 40 to 50 days after completing immunization. So the FDA said, let's take 60 days as a minimum. Let's approve these vaccines on an emergency use and then continue to follow up the vaccinees in the clinical trials, as well as in the vaccinees in the population, under what's called pharmacovigilance, and which is surveillance of the vaccinated population. And then when we have another 3 or 4 months of follow-up, then the companies could apply for full licensure of the vaccines.
Now, you've mentioned the process of prioritization. There is some concern as to whether or not people are going to be able to skip the line, as it were. What is in place? First to begin with, do you have any concerns about that? And if not, what is in place to try to avoid that outside of the guidelines?
So frankly, the operation, the approach we took has been to actually connect with each state in our 50 states, with the governors and the health teams within each state. And they tell us where to ship vaccine, to what hospital or facility or long-term care home, etc., and how many vaccine doses to ship there. We expect and we hope that at that level, which is really much more granular and clear about who should be vaccinated first, there will be no opportunity for people to jump the line. I think it would not be a civic thing to do. But unfortunately, from where we sit, we have no view really on who actually gets the vaccine. It will be each state that decides that and controls it.
Okay. And given the handoff, the impending change in government, is Warpspeed, are you having an opportunity to interact and engage with the Biden-Harris administration to ensure that all of this great work that you've done over these few months get transferred appropriately?
Yes. So first, we have been very careful and actively avoiding any involvement in the political environment and context from day one, even though this is a mission that was decided and financed by the current administration. The whole team has absolutely made sure that our focus was on science and the right data and facts, and focusing on people's safety and on the efficacy of the vaccines, and going as quickly as we can to help save lives. And because of that, and thanks for that, our focus as we go on continues to be exactly the same, which is on making these vaccines as safe as possible, as effective as possible, as quickly as possible. We've had meetings already with the transition team and therefore with the new administration. They are happening very smoothly and very well, and we are absolutely committed to make sure nothing is derailed, nothing is slowed down, and we continue to serve the need of the country.
Any concerns about getting to rural communities or getting to underrepresented minorities who've been disproportionately impacted by the pandemic?
Well, this has been a very high priority for us, frankly, from day one. We have worked very hard as the clinical trials that were aiming to demonstrate the efficacy and safety of this vaccine were being run to make sure that we engage with all minority populations in the country to ensure and engage them to come and participate into the clinical trials in order to be as inclusive as possible so that the data from the clinical trials be representative of the totality of the population of our country. And that engagement, which really happened at the level of the communities through the community leaders and the NIH and the Surgeon General and many others have played a critical role in helping us engage with all our minority populations. We hope we'll continue that engagement now that vaccines are approved and vaccines will be used. But again, practically at the immunization point, it's really each state and the health authority within that particular state that are in charge of deciding who gets the vaccine, where it goes, how many doses go there. We expect them to prioritize the minority population, which unfortunately, as you know, are much more hard hit by this pandemic than others.
Now, you've mentioned the speed with which everything was done, but at the same time, you've identified the fact that on safety in particular, there were no corners cut. The name Warpspeed may raise some anxiety in some of our health professionals. Can you probably articulate why that was chosen? And I recognize the pandemic and what you've done to probably combat some of that concern that people may have about what exactly was done in terms of the timeline.
Yes. So frankly, and I take accountability, of course, for it. But when I joined this mission on May 15, the name Warpspeed was there already. I agree that it could confuse the way by which we went about developing these vaccines and producing them. I can tell you that we have exclusively focused on the best science possible, and we haven't cut any corners. What we have done is we took financial and operational risk. We run everything in parallel rather than in series, one thing after the other, as happens in normal life, because most companies would never invest in manufacturing a vaccine before they know it works. They would never invest in preparing for phase 3 trials before they know that the phase 2 trials have worked. What we have done through the partnership between the Human and Health Services agencies and the Department of Defense was to put as much resources as possible, including financial resources, but critically a lot of human resources and logistical resources, to be ready each time as we were able to go from one step to the other to instantly move to the next step, and always focus on the science and on facts and data. Since the month of July, after we signed the agreement with all the companies and it became legal for us to talk about them, we have embarked on total transparency with everything we're doing, because we believe that transparency and the capacity for all experts from around the country to look at the data, as has happened today, live on TV with the FDA and its independent advisory board made of several experts, all people can access the data, look at the data, analyze and interrogate the data, and make their recommendation. And my ask, frankly, and plea for all Americans, and especially the minorities that unfortunately have suffered historically from a number of discriminations, among other things, on the aspects of access to health, is to listen to keep your mind open, please, and just take the time to listen to the facts and to the data as shared with you by the experts that you trust, and then make up your mind. Because I believe once you go through that process, you will see that these vaccines have been developed appropriately. We didn't cut any corners. They are incredibly efficacious, 95%, and they are very safe.
And as we close, Dr. Sloy, as we try to help you and be and assist, what is the best way that we can help you to continue to be successful with this process?
Well, frankly, is to continue to engage the population, the minorities with whom you are their leaders, and you have the capacity to engage much more strongly than people, like me or others that are not part of the community, to engage the population, to help them either continue to participate into clinical trials, because there's 4 more vaccines in development. We need many vaccines to be able to immunize the whole population in the United States and in the globe. And secondly, to also agree to keep their mind open, to translate the scientific and technical data to them as transparently as you can, to help them finally make the best informed decision, which I hope will be a decision to be immunized, because that's the only way we're going to get out of this pandemic.
All right. Thanks again for joining us, and we appreciate all the work that you've been doing.
Thank you
to help with this. So thank you very, very much.
I apologize, I cannot be at the Q&A later on. But
no, we appreciate you taking time. I know it's a very busy time for you, as we can all imagine. So we really appreciate you taking the time to spend with us.
Thank you.
I'd like to turn it over now to the esteemed president of Morehouse School of Medicine, Dr. Valerie Montgomery Rice.
Thank you, Dr. Frederick. Nice to see you. Always nice to share the podium with you. And I have the opportunity today to actually interview and introduce us to Dr. Nancy Mezanier. And so I think she's going to join us. Dr. Mezanier, how bad did I mess up your name?
My husband would be proud.
Okay, good. You know, that Southern accent sometimes messes us up. So you are the director of the Center for Immunization and Respiratory Diseases at the CDC, and you are leading the vaccine task force for the COVID-19 response. Can you first explain to our audience, what does that entail, and how are you connected with the Operation Warpspeed initiative?
Sure, I'm happy to try to explain that. I think the language can be a little confusing. So at CDC, the vaccine task force is part of the large CDC response to the COVID-19 pandemic. Our task force has been working since the spring to get the country ready for COVID-19 vaccines. And now that the vaccines are available, we're focused on implementing vaccination with the goal to get high vaccine uptake across every corner of every part, every one of the communities in the United States as an important tool to end the pandemic. So we have right now almost 500 people working 24/7 on a huge list of things, including helping state, local, tribal, territorial partners with planning and executing vaccination. We're doing end-to-end data systems to ensure smooth operations. And really importantly, we're working hard to educate healthcare providers and partners and the public about this vaccine. And finally, we're evaluating the safety and effectiveness of the vaccines.
So our previous speaker talked to us, Dr. Sawyer, about this warp speed. And we know that there's been rapid development, but I think it bears repeating again. So let me ask you this question. How can we break it down to the public of why we had rapid development and what that actually means?
Yeah, thanks for asking that. It actually was interesting when Dr. Slawi answered, because I was there when the name was chosen. And what I can tell you is the person who came up with that name is a Star Wars aficionado. I guess it's Star Trek aficionado. And I know what he meant when he said it. And I think, in retrospect, perhaps it wasn't the best name, because I think people did interpret it as somehow being going fast by cutting corners. And as Dr. Slawi said, that's not true. The size and scope of the clinical trials are similar to any studies that you would see for any other vaccines that are used in the United States. The vaccines got here so quickly because, first of all, they were developed based on years of scientific research. If it wasn't for the scientists that had already done that research, these vaccines wouldn't have moved so quickly. And then, as Dr. Slawi said, what Operation Warp Speed did was really try to minimize any delays between different phases of the study so that there were no delays. And they also produced vaccine even before the studies were done, which is something that isn't normally done. And finally, frankly, the clinical trials were really big, perhaps bigger than what we would normally have seen. And because they had so many sites, they could enroll people really quickly and end quickly. Finally, what I would say is that it just also is that the technology that is used to develop this vaccine is faster, and it produces a lot of vaccine more quickly than other vaccine development. One thing to understand, though, is despite the speed of development and getting the vaccine so quickly, less than a year after the virus was identified, FDA has followed the same rigorous standards of approval. And CDC is using the same methods and standards as they use for any vaccine recommendations.
I think, okay. So now, this Advisory Committee on Immunization Practices, the ACIP, I had the opportunity last week, or whenever it was, a week or two ago, to listen to the Pfizer, all is running together. Today, I didn't get a chance to listen to the Moderna. But tell us what the responsibilities of that committee is compared to what the next step is, because I know that around 2 hours ago, they approved the recommendation, right, to go to the FDA. So tell us the difference of what all that means.
Yeah, thanks for letting me clarify this for people. Both the FDA and the CDC have their own advisory committees. So the FDA's advisory committee met today. And they make recommendations to the FDA about authorization or licensure of the vaccine. CDC's advisory committee is called ACIP, the Advisory Committee on Immunization Practices. It's an independent committee that has advised CDC for over 50 years on vaccines. The voting members of our advisory committee are top scientists, and importantly, they meet rigorous criteria to ensure they have no conflict of interest. We also have a member of the community who is on that committee and votes. The vaccine stakeholders represent the groups responsible for implementing their vaccines, and their voices are really important because it's really not just about making good recommendations. They have to be recommendations that are practically applicable. So our committee reviews the data, they ask hard questions, and it's done in a public forum so that anyone can listen to the discussions. And we always make time for public comment. In this issue around COVID vaccines, ACIP has two responsibilities that are slightly different. One is ACIP makes recommendations to the CDC director for use of the vaccine. And that's a little different than FDA. FDAs are authorizing the vaccine. ACIPs are recommendations for how to use the vaccine. And these include things like clinical considerations and administration materials. I'll give you an example. FDA listened to debate and discussion around pregnancy and basically said they weren't going to offer a recommendation around the use of vaccine in pregnancy. ACIP worked with the appropriate stakeholders, that is the doctors and healthcare providers that take care of pregnant women and babies, basically came up with a recommendation to help clinicians who have to give advice to pregnant women about whether they should get the vaccine or not. And what ACIP said was that pregnancy shouldn't be a contraindication to getting the vaccine. The second responsibility of ACIP is to make recommendations around prioritization of vaccines. And so it's ACIP that took the input from the National Academy, from the World Health Organization, and from a variety of groups that get stakeholder engagement and said the first vaccine should go to healthcare providers because they have borne so much of the brunt of this pandemic. And the other priority is for long-term care facility residents who have been where a lot of the mortality has been. This weekend, ACIP will be discussing evidence on the Moderna vaccine. And then secondly, and really important, I think, they'll be talking about the next priorities. And it's going to get pretty complicated to think about the priorities. There's a lot of agreement in the country in those first two groups. The groups after this, most people are thinking around adults who are older and with underlying illnesses because they are where a lot of the disease and the hospitalizations are, but also around essential workers, especially those essential workers who have to deal with the public in their jobs. For example, people who work on public transportation, they can't telework, they have to be facing the public. And a big principle that ACIP is really putting front and center is the importance of equity when they are making these recommendations.
I was definitely listening in when the first part of the discussion with the Pfizer, and I was really impressed with the fact of how transparent the discussions were, back and forth. Do we have justice in there? Do we have equity in there? Are we making our decisions based on science? And they also talked about the implementation strategy. They also talked about the fact that most healthcare personnel, whether you're a physician or a nurse or you work in the hospital, all of us know we have to take the flu vaccine by a certain date or your ID doesn't work anymore, or your computer doesn't work anymore. So we are adept at understanding to the benefits of the flu vaccine. So many of our listeners are interested in the recent reports on allergic reactions that occur with the Pfizer vaccine. And what can you tell us about how we should advise our patients? And then I want to talk a little bit with you about the Moderna decision today.
Sure. I think I'm going to set the stage by just saying that, like any vaccines, the Pfizer vaccine can cause side effects. And in their clinical trials, the side effects were mostly mild or moderate. They went away in a few days, but they included pain at the injection site, tiredness, headache, chills, and fever. And frankly, for healthcare systems, we're recommending that they take this into account when they're planning for vaccination of their staff. For example, you wouldn't want to vaccinate everybody on the COVID ward on the same day and then have a large proportion of those people just not feel great the next day. So we know that there are side effects. In the clinical trials, there were no significant safety signals found. But as large as these trials were, there's still only tens of thousands of people. And that's why CDC and FDA not stop monitoring vaccine safety when a vaccine is authorized or licensed. We have incredibly robust systems, and we launched these systems as soon as the vaccination program was launched. Since vaccination started on Monday, we've identified several cases of severe allergic reactions or anaphylaxis reactions in people who have received the Pfizer vaccine, and these are similar to reports that we've gotten from the UK. Now, we are still actively investigating this. In the meantime, we're recommending that people who have a history of anaphylaxis to vaccines or injections should be careful and consult with their healthcare provider. Everyone who receives this vaccine should be observed for at least 15 minutes after vaccination. If you have a history of anaphylaxis due to any cause, you should be observed for 30 minutes. Please look at our website. We have tools for healthcare providers on the website, including guidance for healthcare providers and how to talk to patients about anaphylaxis. And as more information becomes available, and frankly, more information will become available, that's where you can see the latest.
Unmute me, please. So that means if you're a person who walks around with the EpiPen, you should not go get this vaccine unless you have had really clear discussions with your provider. Is that correct?
So I think it depends a little bit about why you carry an EpiPen. If you carry an EpiPen because you're allergic to bee stings or food allergies, there's no reason to think that you would have an increased risk of anaphylaxis with this vaccine. But frankly, what I tell anybody is if you have a question, call your healthcare provider. You don't want to walk into this uneducated. A big part of our push, and one of the reasons I'm so glad y'all invited me today, is we typically have a long time from the time that a FDA recommendation and an ACIP recommendation are made until the vaccine is on a healthcare provider's shelf and a patient showing up in their office. And part of the goal here is to get this vaccine out quickly, which really means we're going to need healthcare workers to do even an additional lift to make sure that they're well informed, because I expect you all to be getting these questions from your patients, as well as your mom and your dad and your sister and your neighbors and everybody in your community, because I'm getting those questions. I imagine you all are too.
So can we listen to something that I know our audiences are concerned about? And that is whether or not, if you were African American, or whether or not you had a chronic disease, or whether or not you were obese, did we see any differences in the side effect profile in the Pfizer study? I know that they had about 3,900 African Americans or Blacks in that study. Did we see any difference?
We saw no difference in race, ethnicity, obesity. One thing to know, though, is that people with certain underlying illnesses were not included in the study. And that is pretty much normal practice to sort of make sure that you pick a population where, you can understand their side effects. So every iteration that you might think of somebody who looks exactly like you, they may not have been precisely in the study. And that's why it's so important that after the study is over, we continue to monitor for safety. We're going to be looking for exactly those kind of signals to make sure that nothing unexpected occurs.
What was approved for Moderna today, 2 hours ago?
Yeah, really exciting. So again, the way that FDA works is their vaccine advisory committee reviews the data, and then they review the data that FDA reviews. So their meeting today included a presentation from the company, but also a presentation from the FDA scientists who themselves review all that data. They don't just take Moderna's word for it. They actually redo the analysis themselves. And then the advisory committee debates. Again, this was also projected so anybody can watch it. And they recommended to FDA that FDA approve the emergency use authorization. Now it goes back to FDA and they consider that, they look at the data and they work with the Moderna company. As Dr. Slawi said, we are anticipating that there will be an approval of the emergency use authorization, but it really is on FDA's court right now.
Is there any difference between the effectiveness of the Moderna versus the Pfizer vaccine? So if I got a choice, if one should ever have a choice, which we don't right now, should I choose one or the other?
There is absolutely nothing that I have seen so far in the effectiveness data or the adverse event side effects data that would allow you to make a decision about one versus the other. Now, it's early days. The vaccines are incredibly similar, but they're not identical. So in addition to monitoring the safety, we are going to continue to monitor the effectiveness, because same thing, what happens in a clinical trial doesn't always exactly explain what's going to happen when it's in every corner of the United States. Now, there is one important difference between the vaccines. Their storage and handling are quite different. So the Pfizer vaccine is packaged in large pizza boxes, and it is packaged frozen. And that means that for some communities, for some healthcare workers, it just isn't practical, especially, for example, if you're in a really rural area of the country. It may be that your health department says, you know, that Pfizer vaccine is actually hard to get out to every corner. And the Moderna vaccine, because it doesn't require such stringent temperature and it's packaged in smaller quantities, it may be easier for health departments to get that out to certain parts of the population. So not only may you not have a choice because both vaccines aren't there, but you might not have a choice, especially in these early days, because of how the operations are rolling out.
And let's make sure our audience understands that once you get the vaccine, are there going to be studies to ask people to enroll or to, you know, check their symptoms every 3 months, 6 months? What's going to happen once I get the vaccine?
And thank you for allowing me to talk about this. I think this is a really important part of what we need to ask your viewers to help us with. So in a clinical trial, people who get the vaccine are monitored compared to people who got a placebo. And then that study stops and the vaccine rolls out in the population in a lot larger number of people and lots different conditions. We have robust safety systems, and those systems are starting now. But in addition to that, to really make sure that we have our eye on the safety from the very beginning, we have a special system that we added. It's called vSafe. It's a text message-based system. When you get your vaccine in these early days, especially if you're a healthcare provider and you're getting it now, they will ask you to sign up for that system. Please sign up. You will get text messages and be asked to report back about your health. And if you have any kind of significant health event, for example, you stayed home from work because you felt sick, you're actually going to get a phone call. We're really counting on that system in these early days to give us early awareness of any trouble with this vaccine. So please, if you're lucky enough to get the vaccine early, help us out by getting more information. You know, if we get that additional information, we'll be able to reassure people, hopefully, about this vaccine.
Thank you, Dr. Mezanier. I know we probably went over our time, but I thought this was some very critical questions to ask the one who's been putting in a lot of work in this area. So thank you so much for your time, and I hope you can join us for the question and answer session.
Thank you.
Dr. Frederick, I turn it back over to you, I believe.
Yep, thank you again, Dr. Montgomery-Rice and Dr. Mezanier. Appreciate it very much. Earlier today, Dr. Thompson had the opportunity to speak with Dr. Marcella Nunez-Smith, who is the chair of the Biden-Harris Health Equity Task Force. Unfortunately, she couldn't join us live, but she did engage with Dr. Thompson earlier. And so we'd like to show you that 5-minute interview right now. So I'll turn it back over to you, Mr. Ellis.
Hello, this is Dr. Reed Tuckson, and we are so glad to be joined now by Dr. Nunez-Smith. Dr. Smith, you will be the chair of the Biden-Harris Equity Task Force. Tell us a little bit, please, about this position, and particularly we're interested in the priorities that you will focus on that are relevant to COVID-19.
Thank you so much, Dr. Tuckson. It's a great pleasure to have the chance to talk to you about this task force. I think this is such an important moment for us in our country. This is going to be the first time that there is a task force focused on equity specifically coming out of this COVID-19 pandemic. I mean, everyone knows that disparities didn't show up during this pandemic. They predate. We know this is the result of structural inequities, racism, and racial injustice in our country. And here's an opportunity for us to think not only about what we need to get to the other side of COVID-19, all of us really and truly, but even beyond. And so, this task force really is informed by the vice president-elect. When Senator Harris put forward legislation to create a task force such as this, we're really excited that President-elect Biden is going to execute this task force into existence on day one. We're looking to all the things that we know matter: access to high quality healthcare. We're thinking about better data, quite frankly, so we know exactly where we are in terms of the disparities and the success of our interventions. But we also will look to the states where there are great models. So many states and local municipalities have stood up task forces in this time that are having success. And so a lot of work to do. Our list is long, but we're looking forward to doing that in partnership.
In regard to that, a lot of us at the Black Coalition Against COVID appreciate the importance of elements like housing and food security and so forth. Do you think you'll have a chance to reach out and partner with other agencies outside of HHS?
Yeah, we're very excited about this. So the social determinants of health, here's the opportunity for us to take a whole of government approach. We know this is going to be key and critical, and that is really why the task force, we think, can be a great platform to advance some of those collaborations we know are key.
And relevant to the agenda for tonight, you are also the co-chair of the Biden-Harris Transition COVID-19 Advisory Board. Do you have any tips for how we can more successfully overcome some of these barriers that we're facing in getting our patients to enroll in clinical trials and for vaccine acceptance?
Yeah, absolutely. So this is really one of the top priorities for us now in the advisory board. I have the pleasure of co-chairing along with soon-to-be Surgeon General Vivek Murthy and Dr. David Kessler, bringing together really a phenomenal group of scientific experts. And we're working with policy teams that have been kind of at this from the campaign and before. We know that we have a challenge here in terms of communication, messaging, really just general understanding. What's been lacking is some federal coordination, quite frankly, around that. People have questions about safety, efficacy, even cost. We should be addressing those head on. Moreover, right, we need to make sure there's representation, not just in the clinical trials key, but at every sort of decision-making point. And really there has been, and people need to be reassured about that leadership and how that's different today than it has been historically. So we have work to do without question to make sure healthcare providers in particular have the information they need to make decisions about their own vaccination and for their patients.
And as we think about the dissemination challenges, I think a lot of us are worried what happens at the local level. There have been federal advisory committees and the ACIP have made recommendations, but down on the ground, in the last 30 seconds that we have with you, do you think, what can we do to be helpful in that regard?
Yeah, it's going to be hyper-local at the end of the day, but we need federal guidance, and that has been missing. But we know that when it comes down to, just wonderful partners like the coalition, the work that you and everyone else is doing to make sure that there is good information to battle the misinformation. That really is what we have to do. Lead with science, lead with scientists of color, providers of color, to bring those messages to our communities that have been so hard hit. So thank you for all you're doing.
Well, thank you for what you.
All right. Again, I want to thank Dr. Nunez-Smith and Dr. Tuckson for doing that earlier. Very important information. Without further ado, I'd like to introduce you to the president of the National Black Nurses Association, Dr. Martha Dawson.
Thank you, Dr. Frederick. It's great to be here tonight, and I'm going to have a conversation with Dr. Lauren Smith. And Dr. Smith is the Chief Health Equity and Strategy Officer for the CDC Foundation. And this is a new position, I understand. So my first question for her is, why was this position created?
We think you're still on mute, Dr. Smith.
Okay, how many times have we all done that? Oh my gosh, in this land.
I did it earlier today, so join the.
That's okay.
I just want to thank you for having me, and for, it's an honor to follow Dr. Nunez-Smith, who is, so deep into this work. But, as she pointed out, and as all of your viewers know, COVID-19, while shining a light on or illuminating disparities, didn't create them. We all have experienced and know that there were significant health inequities that were existing before and that we could have predicted would play out. And so the CDC Foundation, as you know, recognizing that, created this role with the understanding that we can't get to this vision of a healthy, thriving, resilient collection of communities without an intentional focus on equity.
Okay, great. That is really great. So what will be your priorities while you're in this position?
Well, our first priority really are to ensure that the foundation is using every means necessary, every means at our disposal to drive equitable impact and success in what we're doing. So we're focusing on achieving that vision, and that means through partnerships with community-based organizations, through partnerships and collaboration with other funders. And obviously, because of our unique situation and being so connected to the CDC through our partnerships with them and the amazing work that they're doing in promoting public health across the country.
Okay, so you are a little different than the CDC. So not all of our participants may know about the CDC Foundation. Will you explain what the CDC Foundation does and their role to combat this pandemic?
Well, I thank you for that. And I'm glad we were able to sort of clarify. So the CDC Foundation is an independent nonprofit that was actually created by Congress to support the CDC's life-saving and public health infrastructure work across the US and around the world. We are a nonprofit. We are linked to CDC in name and in our focus on supporting public health and in their work, but we are a separate entity. And I would say that in terms of responding to the pandemic, in January, the CDC Foundation activated an emergency response fund to provide support to the rapidly emerging needs that people were seeing and were identified as being necessary to address COVID-19. So those funds were used to meet needs that were identified both by the CDC and the work that they were doing, as well as by local and state health departments and what they needed to respond to the health threat. So this included things like PPE for frontline workers, providing laboratory and medical equipment. The foundation hired over 1,000 surge staff to deploy in health departments across the states and territories. These are epidemiologists, lab professionals, really seasoned public health folks to add on to the public health workforce that already existed.
You know, that's really great. I'm glad to hear you talk about the public health aspect of this, because many people don't understand that when you're talking about a virus such as this, public health is really important. You know, we hear a lot about the hospitalization, but that is because people are sick and need acute care. But the promotion and prevention of health really is in that public health space. So my last question for you is, this pandemic has exposed the many health inequities and disparities that we heard about now for the last couple of months, and we hear about it every time we have a crisis in this country. So how do we address this now moving forward?
Well, I'm really glad you asked that. And, you know, I would say that I imagine that many of the folks that are watching not only have heard about it in the last few months, they see it every day when they go to work and in all of their clinical practice, because it's confronts them. I think for us moving forward, this gives us an opportunity and frankly a responsibility to use this time to address and to the root causes of the health inequities we're seeing. It's not a surprise that, you know, many of our communities and populations of color are experiencing this disproportionate burden because of the disproportionate burden of health harming exposures that they had before. So what we need to do is get to the root causes of how those things played out And so our role in the CDC Foundation and with our partners is to really accelerate that. I believe that this gives us an opportunity to focus on building up communities, to focus on building resiliency now that we have people's attention and people, can see the connections that we all have to each other. And we're focused on doing that.
Okay, thank you very much. We appreciate your time, and please stay with us for questions and answers section. Thank you again.
Thank you for having me.
Okay, Dr. Frederick, back to you.
All right, thanks, Dr. Dawson and Dr. Smith. Excellent. Now I have the opportunity to introduce Dr. Benjamin, who's the Executive Director of the American Pharmacy Association. And I would like to start, Dr. Benjamin, by asking you a question about the manufacturing coming down from the manufacturer all the way down to the distribution to the states and so on. How comfortable are you and your members that this process is set up in the appropriate manner and will work well in terms of getting that distribution and supply chain?
Well, let me thank you very much for that, Dr. Frederick. Every state and territory has a plan. And in fact, for our colleagues, if you would go to the cdc.gov website and then type in the search engine, COVID distribution plans or COVID vaccine plans, you can see the executive summary for every one of those plans. We know that those plans have been written pretty much at the state level. We also know that they're evolving because a lot of things are changing in terms, particularly around how much vaccine is going out the door. That continues to change. Having said that, those plans have been reviewed. They're solid. There will be some changes over time, but I do think that like any plan, the minute you put it in place, you have to remodel it. But so far it seems to be working. It's not going to be smooth. There'll be some bumps along the road, but all in all, I think we're pretty pleased with the start of this program. But as you know, you've got to ramp this up. And as we ramp this up, we're going to all have to pay a lot more attention, particularly around issues around equity in our communities.
Now, the vaccine is going to be given at pharmacies in the country as well. That's one of the distribution outlets, especially when you look at the long-term care facilities, et cetera. What role are pharmacists going to play in ensuring, again, that there's equitable distribution and as well really impacting in terms of follow-up, et cetera, and how is that going to be coordinated?
Well, certainly early on, many of those pharmacists are going to be actually going into the long-term care facilities. So to actually do the vaccinations in those facilities, that's particularly important for the Pfizer vaccine because of the ultra cold storage requirement. It may be a less so with the Moderna product. Having said that, every long-term care facility has a physician who's involved in the care of those facilities. And I would encourage all of us who are providing care for seniors and long-term care patients to make sure that you know what the plans are, that you've linked up with those pharmacies, because you're still responsible at the end of the day for the clinical care required in those facilities. And to that extent, I think you ought to make those linkages.
Right. And then as we close, any messages in particular that you want the public to be aware of as they engage with their local pharmacists? Pharmacists have been playing an ever-increasing role in our healthcare system. And what are some of the things you'd want our audience to be aware of in terms of how they should be engaging with their local pharmacists?
Yeah, I think that's important that we make sure that patients who get vaccinated anywheres, I want to make sure that you link back to your primary care provider to make sure they are aware you've been vaccinated so that they can handle anything that happens. If you have an allergic response, they need to know about that. If you have any other medical condition, they need to know about it. I think that if you have any questions about getting vaccinated, we're trusted messengers, and we should make it our business to reach out to their patients and make ourselves available to all of their questions about the need for vaccination. And of course, I believe we should all encourage our patients to be vaccinated.
Okay, I appreciate that. And then I guess my last question from a public health perspective, what are some of your concerns in terms of the equitable distribution that should be occurring through the system? We've obviously underrepresented minorities are where we are concerned. And so from the public health aspect, any advice or anything that you in particular are going to be looking for to ensure that that equitable distribution is taking place?
We're going to be watching this distribution like a hawk. And, we know that the system is not designed for equity. And so that means we have to be proactive to make sure our patients are getting the vaccinations that they need. We need to be proactive to advocate for health equity. We need to be proactive in ways in which we ourselves need to walk the talk. That means we need to get vaccinated, and we need to talk to the resource allocators and demand that our populations and our patients are adequately treated with the care and dignity and access that they deserve for these vaccinations.
Right. And Dr. Benjamin, I think I introduced you as the Executive Director of the American Pharmacy Association. You're the Executive Director of the American Public Health Association. So I apologize for that. We're going to have questions for you in the Q&A as well. I'm sure there'll be lots of questions. So thanks again for joining us. And
thank you.
Getting some questions to you again later on. I'd like to now introduce Dr. Leon McDougall, who's the president of the National Medical Association, and he has a couple of folks that he's going to be engaging with to ask some questions. So over to you, Dr. McDougall.
Thank you, President Frederick. And joining us this evening, we have Dr. Brian Thompson, who is a practicing obstetrician and prominent member of the Association of American Indian Physicians. Hello, Dr. Thompson.
Hi, how are you?
Doing well. To start, could you speak to the special challenges that physicians from the Native American community face during this COVID-19 pandemic and face with the COVID vaccine distribution?
Yes, absolutely. I'd like to say first, Sagoli Scano, and that's hello and peace from the land of the Haudenosaunee and from Upstate Medical University. Native Americans within the United States have some unique challenges in terms of the vaccine distribution itself. And first and foremost, it's trust within our federal government, trust within the Indian Health Service, which provides health care to the Native American population. But also that is overcoming the lack of resources that we have in Indian country, lack of funding in terms of health care, but also things that we don't think about, certainly in rural areas, lack of access to care and lack of a distribution system itself. But most importantly, in terms of vaccine distribution for the Native American population, it's the protection of our elders. Our elders are our most important resource within our Native American communities. When you look at some of our nations within the United States, Native nations, there are only somewhere few natives that speak their language. And to lose any of them is to lose our culture. So when we look at within the Native community distribution of vaccine, most Native providers would actually put our elders before themselves, because if we lose our elders, we lose everything. We lose our culture, our language, our songs, our ceremonies. It's that important to us.
Well, thank you for sharing that, the importance of older persons in the American Indian population. And so what advice would you give to physicians serving the American Indian tribal communities as it pertains to advocacy?
Yes, absolutely. The most important aspect, I think, in terms of any of our communities is visibility, for us to be out there helping to protect our own people. And I think one of the things I'd like to let you at least to explain to you is that word that I started out with when I said Sogoli, hello, in our Oneida language, which I'm a citizen of. It just doesn't mean hello. What it means is I see you, but it has such a deeper meaning. It means you're there, you're visible, you matter, you're a part of this of not only just life, but everything that it represents. That you're visible. And I think when you look at our own communities of color, no matter where you come from, invisibility is sometimes one of the worst forms of racism that we have. So that invisibility we extinguish every time that we say Sogoli, means you're visible, you're there.
Well, thank you so much for your time and your commitment to Native communities, and we wish you well in Sogoli.
Sogoli, Ona, appreciate you. Thank you.
Thank you very much, Dr. McDougall, Dr. Thompson. And now I'll turn it back over to Dr. Valerie Montgomery Rice again, who will take us through some questions.
All right. Thank you, Dr. Frederick. All right. So I think I have joining me Matt Eyles, E-Y-L-E-S, who is the president and CEO of American Health Insurance Plans. Hi, Matt. A couple of questions. Thank you for joining us today. So I'm looking at, I have my health professional hat on, and I know that there's a little bit of confusion about the administrative process that's been engaged with in the vaccine administration and reimbursement. Can you talk us through how this will work initially with the mass vaccination public clinics, and then when private practices and other clinics become involved? You're mute. Can't hear you. Wayne, can you hear him?
No, I can't. I think in the meantime, we could probably bring Dr. Brooks in.
Let's bring Dr. Brooks in, and then until we can get Matt's, because we really are interested in his answer. Dr. Brooks, who is the Chief Medical Officer of the Watts Healthcare Corporation and former president of the National Medical Association. Dr. Brooks, how you doing? Can you hear me?
I can hear you, yes.
Great. So I know you've been listening in on the conversation so far. So tell me, what concerns you as a private practitioner who is working in one of the most challenging communities in our nation? What is concerning you about the development of this vaccine or the allocation of this vaccine, or how it's going to impact your practice?
Well, one concern I have is uptake of the vaccine. So I think the concept of vaccine hesitancy among the African-American community is very important. Vaccines don't save lives, vaccinations save lives. So the primary approach I have is to address people's concerns. It's crucially important that we understand that where they're coming from is reasonable. There is some concern regarding the healthcare community as it relates to those involved. So what I do is I talk to them, I address it, and then it was stated by Dr. Nancy Smith, lead with science. But do understand that hesitancy is an emotional, psychological reaction also. So go to where they are, give them the information, and bring them in. Now, as it relates to the private physician, or if you will, the community, as it relates to distribution, there are some challenges. The vaccine right now is going primarily to large institutions. So I am happy to report that here in California, what is happening now is we are being asked if we would like to receive vaccine from the California Department of Public Health. Now, there's significant requirements. You have to determine who's going to administer the vaccine. Do you have the ability to store and distribute? Can you handle and report adverse reactions? Can you have the credentials of those who are going to be providing the vaccine? But right now, it is moving in our direction. And then lastly, I'll say about equity. I am on the task force here to determine who gets the vaccine. The first pass was healthcare providers and those residents of long-term care facilities and nursing homes and field assisted living. The next pass is essential workers. Now, here in California, there are approximately 11 million essential workers. When you look at the workers in California, those are 68% of the total workforce. So if we can give equitable distribution to essential workers, then we can have equitable distribution of the vaccine.
Thank you. Very succinct answers. And just one practical question. Patient comes in who has had a history of allergic reaction, but also has chronic diseases and tells you that she's an essential worker. How would you advise her to consider the vaccine?
So that was addressed earlier. I would, again, look at what the specific reaction was in terms of allergic reaction. If she did not have an anaphylactic reaction, and if I could be clear about it, as an essential worker, and also what we're looking at, the degree of exposure she may have in her work. You mentioned the fact that she may have a chronic condition, so she's at higher risk for an adverse condition. I would likely give her the vaccine, and as we're doing now, as indicated, recommend it, monitor her for 15 minutes and be ready to respond were she to have any response. We know that those responses generally are immediate. So if it doesn't happen, it doesn't happen. And if it does happen, I'm ready to treat it. And when she leaves, she is protected from COVID, 95%.
And one of the things we know, for many of us who practice, we've had periods of time where we've had to give patients penicillin. They said they had an allergy to penicillin some years ago, and we would give that shot and then monitor them appropriately and be ready to act. And so that's what I hear you saying, Dr. Brooks. So thank you so much for joining us.
Okay.
I think next we're going to have Mr. Stanley Bergman. He is the chairman and CEO of Henry Schein. And so thank you, Stanley, for joining us. And I'm going to get right to your question. You are focused on serving the needs of office-based healthcare professionals, and you have been very focused on pandemic preparedness and response over the years, including co-founding the Pandemic Supply Chain Network. And you have a role on the HHS Supply Chain Task Force, I understand it. What do you see as the role of the office-based healthcare practitioner in response to the pandemic, and how can we maximize their engagement in the provision of the vaccine?
Dr. Valerie Montgomery Rice, thank you for hosting this evening. Dr. Fredericks, thank you for hosting this evening. Henry Schein has been involved for decades in public-private partnerships. We founded the Pandemic Supply Chain Network through a public-private partnership formed at the World Economic Forum alongside Gavi and CEPI. We worked on this with the World Health Organization, the World Bank, HHS, companies like UPS, BD, and 60 other members of the private sector. The goal was to work on ensuring that adequate PPE was available, and specifically in our field to office-based physicians and dentists. Well, I'm very worried. COVID has laid bare the terrible racial inequities in access to care we face in this country. And I think it's imperative that all sectors work together to ensure fair and accessible care. In other words, access to vaccinations, and I might add, testing. The backbone of healthcare in communities is the office-based practitioner. A successful vaccination campaign requires trust, education, and accessibility. We must therefore focus on these three pillars, in my view, to overcome the barrier that contributes to the lower vaccination rates we see in communities of color, in other communities as well. Trust is the foundation. Transforming a vaccine into a vaccination is the big concern in dealing with health equities. We have to identify patients of high risk and provide patients with guidance. Who is better to do this than the office-based practitioner? The people on the screen work day in and day out in the communities. These practitioners are well positioned to provide education to the patients. These practitioners can get the word out to the community. And here's my concern. My concern is it is important, of course, to vaccinate healthcare practitioners as a priority in their hospitals and in their healthcare settings. Of course, long-term care patients, but patients in the communities. My concern is the availability of vaccines to the office-based practitioners, those practitioners that are working day in and day out with patients. You know, this particular group of people here tonight, you have a lot of power. And I think it is critical that you go to the appropriate people in authority, in the communities, in the state administration, in the national, federal government, to make sure that healthcare professionals in your communities, the superheroes actually of much of the COVID period, the people that were on the front line and are on the front line, be given access to these vaccines in a way that is similar to the way that you've gotten access to vaccines for other diseases.
Thank you. Thank you.
Paperwork has to be minimized. Thank you very much.
Thank you. Thank you, Mr. Bergman. And I want to see if Matt Owls, did he get his audio repaired? Because we did have one question we wanted to ask him.
Can you hear me now?
Matt. Right, great, Matt. So let me ask this question because this is on all of these healthcare professionals' minds. So right now, we are hearing that potentially it's going to be covered by insurance. We know there's some administrative things that have to be taken care of. Can you talk us through what this really looks like in a mass vaccination public clinic, and then how will private practices get involved, and who's going to cover the cost for all of this?
Great. It's such an important question. The first thing to remember is that the federal government is paying for the doses that they have purchased, right? So there's not going to be any outlays for the cost of the vaccine itself, the product. Really what we're talking about here is vaccine administration fees. And for mass vaccination clinics, the federal government's putting together rules to be able to make sure that they can bill, do so-called roster billing and bill multiple vaccinations at a single time and get reimbursed. When we get into the more traditional administration through pharmacies, through physician-based offices, it's important to distinguish between different types of coverage that people might have. So you might have commercial coverage, say through ACA marketplace coverage or through employer-sponsored coverage. And in that case, COVID vaccines will be covered as a preventive service without any cost sharing. Health plans will provide an administration fee to anyone who's giving the vaccine. And that includes vaccines that are delivered both in network and out of network. Now, when you turn to Medicare, it's a little bit different. The Medicare Part B program, at least for 2021, will cover all vaccines. And that includes seniors who are enrolled in traditional Medicare and also those who are enrolled in Medicare Advantage plans. So we'll just bill the Medicare program directly for that. Finally, I'll just note in Medicaid, it's yet even a little different. And so Medicaid coverage depends on state rules. And we know that coverage without cost sharing is required in most states that accepted greater federal funding under recent legislation. Some states may need to make some adjustments, but again, it will be covered without cost sharing and those administration fees will be paid. The final point here is for those people who are uninsured and underinsured in very limited types of plans, there's essentially going to be a fund that's available to cover the administration fees through HRSA. And so these administration fees are going to be paid. I wish it was a little more simple and straightforward, but it's important to know that We want everyone to get vaccinated without any cost sharing, and that providers need to be given administration fees.
We appreciate that. I know we're running out of time, but so if you can send us a link in the chat room that gives where these regulations can be found, we appreciate it. Thank you for joining us. And I'm going to turn it back over to Dr. Frederick.
Sure. Is Dr. Rios with her? Dr. Rios
Yes.
is the president and CEO of the Hispanic Medical Association. Thanks for joining us.
Thank you.
You know, one of the concerns that we have is when we look at the data in terms of vaccine hesitancy, the Hispanic community, it shows very significant numbers who are apprehensive about getting the vaccine and, again, disproportionately impacted. Any words that you have in terms of how your association is approaching trying to close this gap?
Yeah, the National Hispanic Medical Association, thank you very much for inviting us, is very proud to be part of this meeting. Let me just say that we have doctors on the ground getting vaccines this week, and very happy to see those role models for their patients, because our Latino community needs to trust their doctors and know that the vaccines are safe and effective. We have been part of the HHS committees. We have doctors on the CDC committees and the FDA committees, and also we've been part of the vaccine consultancy project to see every step of the way how important science has been to show how important these vaccines are and how safe they are. I think for our communities, they need to have more media attention, more education, because many of our Latino essential workers do not have the time or the money and not insured to go to doctors all the time to get the information. So we are going to start a major media campaign with doctors and nurses and dentists, pharmacists who are taking care of Latino communities. And our media attention will be with not only ethnic media, newspapers, social media, but also TV and radio. And we'd like to partner with all of you to get more media out to our communities. I think that's the way to go in terms of letting them know how important it is to get the vaccines, so that they know how important it is to decrease the disease in the communities and in their families by getting the vaccines that are out now.
Do you also think that we have had some issues in terms of data collection around our Hispanic community in terms of the number disproportionately impacted, et cetera? And can that then influence the vaccine distribution?
Yes, we definitely have. I think there's only about 30 states in the country that have had data on Hispanics and Native Americans. I think that we need to do better in mandating. In order to have equity in our country, we need to have the data. We need to mandate data collection by race and ethnicity. And we need to encourage all healthcare systems to mandate data collection. But the data does show that Latinos, you know, because they are essential workers and they're in the food industries and the cleaning industries, the hospital industries, they are getting impacted more, up to 5 times more hospitalizations, twice as many deaths as the non-Hispanics. And we need to pay attention to that and get the vaccines to the communities where there are high dense Hispanics living. Especially in the big, metropolitan areas and the rural areas where our farm workers are, inner city areas where we have a lot of people that are essential workers. And I have to say, let me just make one last comment really about all the people in our communities that are not citizens, undocumented people. They're waiting for they have green cards, they're waiting for their citizenship, or they might be new immigrants and just don't know that, as we just heard, that these vaccines are free. The vaccine is important to get, whether you have insurance or not. There will be a way to have the vaccines free for the whole family. And I think it's very important to get that message out to our communities.
Yeah, very important points, Dr. Rios. So again, thanks for joining us. If you could sit tight as I'm going to start asking some questions from the chat. I first want to bring Dr. Mezanier back in quickly before she has a hard One question that keeps coming up in the chat is if you have immunocompromised patients, should they continue to get vaccinated? And people who've had a previous anaphylactic reaction or may have had one while getting that first shot, should they be brought back in to the system?
Yeah, I actually like Dr. Brooks's answer to that last question about the anaphylaxis. I mean, if you have anaphylaxis to the first shot, you're definitely not, unlikely to get the second shot. But if you have a history of anaphylaxis, it kind of depends what the anaphylaxis is to. In general, if you have anaphylaxis to any of the specific components of the vaccine, you shouldn't get vaccinated. If you have anaphylaxis to vaccines or injections, you need to talk to your healthcare provider. If you've had allergic reaction in the past to food, you're probably okay. But again, if you have a question, you should talk to your healthcare provider. In terms of immunosuppressive conditions, I think the problem with that is it's a really broad group of disorders. So it's hard to be specific because as large as these studies were, there were only 30 and 40,000 people, and you can't have enough data to be really specific about every condition. So it kind of depends what it is. Chances are that if you have a patient who has significant underlying illnesses, they probably weren't represented in the clinical trial. And frankly, that's normal for these kind of clinical trials. The first ones out of the gate, they generally try to keep it somewhat restricted. And some people who have more complex disorders are excluded. Now, I think that at least in one of these trials, there were patients with HIV, but I don't know the numbers off the top of my head. And that is something that we'll definitely look into, make sure that information is more available.
And my last question to you is, patients with autoimmune disorders, should they also be vaccinated?
So again, it kind of depends what that is and how well controlled it is. The good part of these vaccines is they moved quickly. I think we're all grateful to have this new tool out there. I can tell you that I had a pretty emotional reaction when I saw those trucks start to roll out, and we got great stories shared from some of the first people who got vaccinated. But when a vaccine moves that quickly, it means that some groups of people weren't studied closely. And that probably includes some people with, again, more complicated disorders. Right now, we're going to say, talk to your healthcare provider. And we also at CDC have a clinical consultation line set up. We'll put that number in the chat. And it's specifically set up for healthcare providers who have complicated questions to get advice as they try to make decisions for their patients.
And I know I said last question, but just to piggyback on that, the subset of patients with comorbidities, hypertension, diabetes, other chronic illnesses, were you satisfied that some of those numbers were significant enough that you think people can draw conclusions that the vaccine is as effective in preventing severe illness in that group of patients as well?
So I wish I could say that I was confident because there was extremely precise data in those groups. There's not. They weren't excluded from all of the studies. I do think that right now we're recommending that all those groups of people get vaccinated. There's no reason to think they'd have more adverse reactions. In terms of effectiveness, the vaccine numbers for these first two vaccines are more than 90% effective. That's a really high number. We'll have to do additional evaluation of the vaccine to see if it looks different in different subsets of the population. But I don't think any of those are reasons for people not to get vaccinated. I think there is enough data that if you have patients with hypertension or diabetes, you should be recommending they get vaccinated, even if it could be a little bit higher, it could be a little bit lower. But again, there's no reason, there's no reason based on what we know about these vaccines to think that there's any reason the vaccine wouldn't work as well in those kind of patients.
All right. Thank you very, very much again for joining us. I'd like to bring Dr. Benjamin, Dr. Smith back. Dr. Benjamin, starting with you. The question around patients who were previously positive for COVID, should they get the vaccine? And Mr. Ellis, do you have Dr. Benjamin still with us? And if not, I'll go back to you, Dr. Rios. In terms of testing in the Hispanic community, do you have concerns about the testing? As you mentioned, there's some concern about the distribution of the vaccine, but do you have concerns as well about testing?
Well, I think the concern about testing is that not everybody's getting the rapid testing, and some people are having to wait, 5 days, 7 days, and that's just, I think what can we do about that? I think it's just important that the public health agencies have the infrastructure and the resources to be able to provide more information in a more timely manner so that we know who has the disease.
Okay. Yeah, Dr. Benjamin, I think I see you back with us. From a public health point of view, as we look at the patients who have already tested positive for COVID and the recommendations, what types of messages are you trying to push out to encourage those patients as well to continue to participate in either vaccine trials or even in getting the vaccine?
Yes, we're absolutely encouraging people who've already had COVID to be vaccinated because we really don't have a real good sense of how long natural immunity lasts if you've been vaccinated. I mean, if you've had the disease. So we are actively encouraging people to do that, and also we're not doing any testing beforehand to see who has and who hasn't. So anyone who certainly wasn't diagnosed or was sick, or even if they knew they had COVID, they should get the vaccine. If they have any questions, they should talk to their doctor.
Okay. And from a public health point of view, we've been talking about the fact that disproportionate impact on Latino community, as you just heard from Dr. Rios, and obviously in the African American community, we heard from Native Americans. What efforts is your association putting in place? Well, what are the efforts you're putting in place to really ensure that vaccine distribution is going to get to those most vulnerable? Because once the economy starts opening up, as Dr. Rios just articulated, you're going to have frontline workers, et cetera, who are vulnerable, servers, waitresses at restaurants, et cetera.
Well, we've done several things. First of all, we continue to work with the federal agencies that are making the priority decisions, and we're continuing to give them advice through the usual formal manners and vehicles. We're also working with at least 2 coalitions. We have an Alliance for Disease Prevention and Response of the public health community that we're working to make sure that those groups are paying attention to health equity. We're also working with the COVID Collaborative, which is a broader group of very, very senior people, including elected officials, to ensure that vaccine education is occurring, that they're part of the $50 million ad campaign that the Ad Council is doing. The Ad Council is also working with the CDC and other groups to make sure that the communities are, first of all, aware that the vaccine is available, and to deal with many of the issues around vaccine hesitancy, which we think is probably the greatest barrier. And let me point out, finally, the fact that the disease, getting COVID disproportionately, risk is much higher than any risk from the vaccine whatsoever. We believe strongly the vaccine is safe and effective.
Okay. And I'd like to bring Dr. Smith back in. Obviously, there's hesitation within the African American community about taking the vaccine. What message can you drive home as to why African Americans should take this vaccine, given the history of the inequities that have existed and the faulty experimentation, unfortunately, that has occurred in some of these communities?
Well, first of all, I think acknowledging that people's feelings of concerns or questions they have are legitimate, and not trying to dismiss or diminish those. So I think first acknowledging the reason and the history that you point out that people may have some of those concerns is really important. Then I would focus on the science and the data. We've heard so much today from Dr. Mezanier and others around the approach the safety approaches that were put in place, the transparency that was put there, the opportunity that other organizations and oversight bodies have had to look at the data and to evaluate it. So that's reassuring. I think that some of the conversations that we've also heard about the risks that our communities have in terms of having diabetes, heart disease, hypertension, and other things that do put them at risk means that it is more important for them to get vaccinated than they might be aware of. So I think that that's important. The other thing I would say is that the desire to sort of wait and see. There's a group of folks who said, well, I may not want to, get it when it's first available. I'll wait and see and see how it goes. I think that's, we're going to want to have conversations with our patients about that because a lot can happen in that intervening period. And we really want people to take advantage of an opportunity to protect themselves, their families, their loved ones as early as possible. But I think the first point is to acknowledge that it's reasonable that people have concerns and to not diminish or undermine that, but then to go to the data and the science to be able to reassure them about that.
Yeah, I appreciate that feedback. And I'd like to bring Dr. Brooks in because Dr. Brooks, when you look at the data, can we have confidence in the data? Number one, because we feel that there was appropriate representation of minority populations in the study. And then two, as a follow-on, but kind of getting on Dr. Smith's point, if we go 5-6 months and we vaccinate large numbers of the population, but very small numbers of the minority population, do we then run the risk of having almost a doubling down on the pandemic disproportionate impact as the economy opens up and we overexpose our brown brothers and sisters?
Yes, so to the first point, I do believe we can have some confidence in the research and the data. African Americans were approximately 10% or more of the clinical trials for both vaccines, number one. Number two, we really haven't seen much in terms of vaccine adverse reactions that was related to race or ethnicity. So there's not a long history of that being a problem in terms of vaccines. Also, the National Medical Association has been meeting with both Moderna, Pfizer, and others to get independent information analysis. So we are looking at that information. As it relates to, yes, if we don't get vaccinated, that's a problem. It was stated earlier that 30,000 were in the clinical trials, which are good numbers for clinical trials. I want to make that clear. But you want 300,000, 3 million, because a lot of reactions happen. For example, it's about 2 to 3 per million when you get these serious reactions like anaphylactic reactions or real adverse reactions that are part of all medications. So if we're not in the vaccinated pool in the population, then how will we know? You also state, of course, that then we're not vaccinated, so we're more likely to have the continued disproportionate effect of COVID-19. So the take-home message for me is to get vaccinated.
And Dr. Rios, the vaccine, the hesitancy in the Latino community, I am sure has its own characteristics, their own concerns about how quickly this may have come about, et cetera. What unique things in the Latino community you think need to be addressed as we try to roll out the vaccine?
So the fact that there are very few Latino doctors, Latino nurses, we're only 5% of the doctors. I think that we need more Spanish-speaking staff to be part of the vaccine rollout. We also need to have again, information that tells our community that they are going to have vaccines that are free and that they need to have them to help their children, their families, to decrease the disease. And also, I think privacy is a big problem, especially among those who are undocumented, that the information collected for the vaccine is not going to go to the INS, not going to go to the other government agencies. And lastly, I would say that there is a big trust issue. Just like the African Americans, there has been research studies done on Hispanics, especially Hispanic women, through time, on having hysterectomies without any consent, both in Los Angeles and in Puerto Rico and other places. So there's a mistrust of any kind of government program. But I do think that what's important is to give the message about how important it is to get vaccinated so that we can decrease this horrible disease that's ravaging our communities, and the economic distress that's happening is not going to go away without having people feeling better and being able to go back to work. And our public health agencies are protecting our communities when they're closing down our restaurants and et cetera, because they want people to stay home and not get the disease, not transmit the disease, but the vaccinations will help with decreasing the disease. I think that's the most important thing.
All right, I appreciate that very much. Dr. Benjamin, with respect to insurance, we heard repeatedly that you do not have to have insurance, but for the practitioners listening, they know that there are fees associated with actually administering the vaccine and those types of things. And we heard from Mr. Isles earlier. Any comments on, for patients in terms of advice of any hesitation they may have about having to pay for the vaccine?
Yes, you shouldn't have to pay for any of those aspects of getting the vaccination. But the truth of the matter is we always know that health insurance is very important. So I'm going to take this opportunity for people to know that the enrollment period is coming to a close in many communities for the Affordable Care Act, and encourage people, if you do not have health insurance now, check and see if you can get enrolled under the Affordable Care Act. This is also open season for many employers. So if you're employed, make sure that you get yourself covered. And for my colleagues that work in safety net programs, community health centers, et cetera, make sure that you have programs that reach out to make sure that you're getting these patients in so they can get their vaccinations at no cost.
Okay. And as we wrap up, Dr. Smith, we've heard about the Tuskegee experiment. Dr. Rios again just emphasized Hispanic women having hysterectomies. What about today is going to avoid that happening as we go forward? And also, there's still a vaccines to come, as we heard earlier. So there are vaccine trials still to come. What about those vaccine trials and how we're set up today with respect to our IRBs and so on that will make it safe for the minority community to participate?
I think that that's an excellent question. And for listeners who aren't aware, there are so many more safeguards in place to protect the well-being and the rights of individuals who participate in clinical research than were in place before. And they've come into being partially because of the kinds of, frankly, just terrible behavior and egregious wrongs that were done in that public health study that was done at Tuskegee. So there's, issues around informed consent. There are detailed follow-up. There's oversight by committees that have to include community members in order to get approval for research and to oversee and to sort of act as a watchdog for the results of the study as they're coming through. Not to know individual results, but just to make sure and that they're observing or following if there's any adverse outcomes. So all of those kinds of protections are in place. I think the only other thing I would say regarding the prior conversation is there's so much misunderstanding of how vaccines actually work that I think part of what our role is as healthcare professionals is to help our patients understand how any vaccines work, and especially how this kind of vaccine, which has this messenger RNA, which is really quite different than any other vaccine we've had to be able to use, so that people don't misunderstand or think they could get the illness, they could get COVID from the vaccine, which is obviously impossible. So I think we have a lot of education that we can do with our patients directly about what happens when our bodies get vaccinated.
Well, I want to thank all our guests. You can see some of our guests here. Mr. Isles obviously joined us earlier. Mr. Bergman, want to thank you. I think we had a very robust discussion. And as we wrap up, I want to remind everyone, you can see this again at blackdoctor.org. You can also go to the Black Coalition Against COVID.org to see this. 2 days ago, I got the Pfizer vaccine. And I have to tell you that it went fine on Tuesday. Yesterday, I felt a little bit achy. And today, I'm feeling absolutely fine. So we intend to lead from the front. I got the vaccine because I continue to practice as a surgical oncologist. I'm operating. I'll be in the operating room again on Saturday morning. My patients have cancer. They're at risk. I've taken care of at least one patient over the course of the summer who I operated on. And unfortunately, during her ICU stay, developed COVID. So with my sickle cell and my type 1 diabetes, I'm certainly at risk. And I felt that the right thing to do was to ensure that I got the vaccine as well. So we do want to encourage you to get information. We want to be clear about that. We're not asking people to just simply go out and get the vaccine because we think it's the right thing to do. We want you to participate in these discussions and make sure that you get all the information that you need. Thanks again for listening to us. And please join us again. You can listen at blackdoctor.org. And again, a Black Coalition Against COVID.org, and we will continue this series of Making It Plain. Peace. Have a safe holiday.